while we're giving folks another minute to jump on, I just wanted to let folks know that our next coalition meeting is November 20th. And I think we'll do a virtual meeting again, probably 10 to 12:30. And one of the things that our core team has been talking about is, since we've gone to a lot of virtual meetings, it's a lot of information sharing with folks, but it's not that same level of engagement that we used to get when we were meeting in person. But I think we'd like to use that time to touch base with folks and get a sense of what people want and need kind of moving forward. Right now, we're all just volunteering our time, and I think we've made a lot of guesses around what coalition members want, but we really want to spend a little time at our next meeting really having coalition members kind of guide what makes sense given where we're at right now and what people want and what people need, so we can be responsive.
Amy, do you need me to manage the admits?
I think everybody should be able to just join, and I did mute folks in case they join late and are unmuted and our speakers are going, but you're a co-host, Gay, so you just help keep your eye on things.
Oh, perfectly under control.
All right, I think we'll go ahead and get started. Welcome to the Iowa Coalition for Integration and Employment. I am delighted to see familiar faces and new faces. I greatly appreciate you guys making time to come today and our speakers. I have to say, I'm so incredibly excited just to have the folks we have who are coming today to really share some insight in what's happening at the federal piece of the federal level and at the state level. And so I think we don't want to spend, I know many of you are going to be really disappointed that we don't do introductions anymore, but I think we're going to just dive right in. We're going to kick it off with Liz Matney. And Liz, I just want to say thank you. And I want to say, I think you were one of the very best Medicaid directors Iowa's ever had. And people know your face because you put your face out there and you made yourself accessible to everybody to share their stories, to share their struggles, to share their successes. And I think you have really changed the landscape of what it means to engage the entire community around that work. And so I want to thank you so much for coming. I can't honestly think of anybody I'd rather help me try to think about and unpack some of the stuff that might have a huge impact on Medicaid in Iowa and across the country. So I don't know, I will put a link in the chat for folks for Liz's and Don's presentations. Liz, do you want to just run your own slides? I think I made you a co-host.
Yeah, that would be fine.
All right. Oh, go ahead, please.
And Amy, what kind words. That just really means a whole heck of a lot to me. And, I have missed seeing everybody on a more regular cadence and being engaged in some of that work. But what I have found is that since I have left state government, there are a number of ways that I can still be engaged and supportive in a capacity that feels good. So I'm still here. I'm still in Iowa. I'm doing some consulting work and really working to help other states and organizations, companies understand how to better serve individuals who receive Medicaid funded services. And so that really is my mission as I continue working on, and I am just so thrilled to be able to still be connected with all of you. And thank you so much for the invitation, Amy.
I love that you're here. Thank you.
Okay, so I'll go ahead and start sharing my screen.
And I'll put a link in.
Can everybody see that? Okay, great. Still seeing it? Okay, it just doesn't show up on my screen for some reason. Okay, so I do not call it the one big beautiful bill. I just say OBA or OB, triple B, A, what, like everybody has their own kind of name that they have for the bill, but OBA is a very, very big bill with pretty significant implications for Medicaid moving forward. And so super, I wouldn't say excited is the right word to be able to share some of these changes with you, but I did want to help everybody kind of think through what it would look like moving forward. Okay, so what are we going to talk about? What's in the OBA and where are we in the process? Like, it's not all effective when it was signed in July. There are effective dates staggered throughout a 10-year period. What are some of the key Medicaid changes that all of you are probably wanting to know about? What does this look like for Iowa? And, some of this is just really fact-based in terms of what is it going to look like financially. The decisions are really yet to come in terms of how to mitigate that. And then just some resources for all of you. And then at the back of my slide deck are some other supplemental resources and context information just in case folks were wanting it. And then we'll have some time because I'm sure you guys have lots of questions and I'm not going to answer all of them before we get to the end. So we'll leave some time for questions and answers. So this was a very, very big bill. I mean, we're talking about over 1,000 pages of policy language. And so as it was going back and forth, a lot of folks were scrambling pretty quickly to read through the bill language, understand what the implications were. And while it started in the House, there was a process where it went to the Senate. The Senate made some changes, and then it went back to the House for final signature or for final approval and voting. And then the president signed it July 4th. This bill is massive. A lot of the focus has been on Medicaid, but it's not a Medicaid specific bill. It's an overall government spending bill. So there are lots of different things included. There's a lot of tax changes included in it. There's Medicare, there's marketplace changes. So with the Affordable Care Act, there was portals opened up for individuals to be able to purchase insurance on the marketplace. Some folks aren't familiar with that terminology, but that was something big that came out of the Affordable Care Act, and there's significant language in related to that. All of the changes that are in OBA also, especially those ones targeting Medicaid, will require some additional federal rulemaking and some additional steps before things are fully implemented. The work requirements, for example, which we'll talk more about, those are effective at the beginning of 2026. The rules and what states are expected to do specifically from the perspective of CMS have not been released yet. And so states are still in a little bit of a wait and see place. A lot of these changes will all require a lot of administrative work from state Medicaid agencies, including updating their state plan amendments, a lot of budget work, and then updating waivers. And all of those will go out through public comment process as well, like they normally do. I do want to note, I can't understate the amount of work that state Medicaid agencies are going to have to tackle in the next couple of years. So please be kind to them. They are going through a lot, and this is not something that they asked for. So just keep that in mind as you're interacting with them. It's easy to, be frustrated and scared about the future, but they are in the same place, I imagine. So what's in the bill? Okay, it's kind of broken into a few different big buckets. There's the eligibility and enrollment pieces that are associated with Medicaid. There's the cost sharing, and then there's the state financing pieces. So for eligibility and enrollment, the work requirements are probably the biggest piece. And that's the piece that has gotten a lot of media attention. We in Iowa have floated the possibility of work requirements several times. As from my previous experience, as we have been looking through work requirements, there's a lot of just administrative work back and forth to actually implement a work requirement model, and then adding on monthly certifications, which this bill does, is additional. And so the amount of savings is going to be an exercise that we all kind of watch the feds and the states go through, because the feds anticipated savings through disenrollments, people who are not complying with the work requirements, getting disenrolled from Medicaid. That's where a lot of the savings are going to come from. But there's also a lot of administrative cost. And so it'll be interesting to see how those things actually weigh out and what the actual result is in terms of, did the hypothesis of work requirements and really getting people employed and engaged in their community lead to them just getting disenrolled from Medicaid and having no other insurance, or were they disenrolled and connected with another healthcare coverage source? So I think all of those things are going to be highly watched over the course of the next 5 years. Again, this requirement doesn't go into effect until January 2026. So states have under 18 months to do all of the programming, all of the messaging related to that, the staffing up that they might need to do. So a lot of work related to that. Additionally, there was some language in, I'll go back to work requirements. Just one more thing that is of particular note that I want you guys to all really anchor into. This only applies to states that have expanded Medicaid. And it only applies to the Medicaid expansion population at this point in terms of how it's being communicated from CMS. So that's the 19 to 64-year-old able-bodied population that doesn't have disabilities. Further, if they are a caretaker of somebody who is under 14 years old, I believe that there's a number of different exemptions at play, and that would be an exemption as well. So I just wanted to make sure we're all kind of level set on the population that it applies to at the federal level. Redeterminations, for the expansion population, so that's in Iowa, that's our Iowa Health and Wellness Plan. They normally go through an annual redetermination process, just like the rest of Medicaid. Now, the requirement is going to be that they are kind of reassessed, or their eligibility is redetermined at least every 6 months. And then just So you all understand the monthly work requirement certifications that will be a part of maintaining ongoing eligibility too. So if somebody doesn't meet in between those 6 months of redetermination, if they're not meeting their work requirement during the monthly certification, that is another area where they can get disenrolled. There was some capping of the allowable home equity claims that long-term care individuals can claim when they're doing eligibility. So it caps it at $1 million. There previously was kind of an ambiguity, and states could have some flexibility in establishing that cap, but this puts it a hard federal cap at $1 million. Then there's some enrollment kind of program integrity pieces, including making sure that states are checking this sounds pretty ominous, the death master file, but it's from Social Security Administration. They have an active log of everyone who passes away so that they can start making sure that they're either stopping the Social Security benefits that they're sending out or appropriately transferring those to a beneficiary. States are already using this information. This codifies it and makes it so that states are required to check it at least every 6 months. I would say right now, probably states are checking it on a monthly basis at least. So that doesn't do much to it. The duplicate enrollment prevention, currently there is a national system called PARIS that does state-to-state checks and identifies when individuals are enrolled in more than one Medicaid program. States sometimes have their hands a little bit tied if they can't verify where the member's actual address is. But this sets some additional requirements up for states to comply with when it comes to duplicate enrollment and when an individual is identified as being in more than one Medicaid program. And then there was a very large rule package related to eligibility streamlining and continuous enrollment that was rolled out during the last presidential administration. All of those have been suspended from going into place until 2034. So they've suspended those rules from deploying for at least the next 10 years. So now we're going into the cost sharing bucket. Again, you'll notice that there's a kind of a theme throughout here that is related to Medicaid expansion. For individuals who are enrolled through Medicaid expansion, there's a new allowance for states to be able to charge a higher copay than they previously had. This allows up to a $35 copay for each service that an individual utilizes. That doesn't mean that states have to implement that at this point, but there is an allowance, extra flexibility for states to implement it. There's also several provisions, not nearly as extreme as had originally been proposed, but there are some provisions around individuals who are maybe legally present, but not full resident or full citizens, and also undocumented individuals. So there's some eligibility restrictions. They pared down pretty significantly what's considered a legal permanent resident and what types of services can be paid for. This is where the bulk of the dollars come from that have been cited as like Medicaid cuts in the OBA bill. And this all has to do with financing arrangements that the state has with the federal government and their providers. So if we backtrack many years, states have, it is no surprise we're dealing with it now. We were dealing with it back then, but states have always been under pressure from healthcare providers that the reimbursement that they provide is not enough to cover costs. And so one way that states and providers got pretty creative about this back in the day was that they developed strategies where the providers would kick in the non-federal, the extra non-federal share for certain provider rate increases to draw down additional federal dollars. So if a state has $10, they want to increase reimbursement, and the equation has to be that they have to invest, let's say $15, but they only have $10. The provider will pitch in the extra $5, which means that the federal government will send the state like $30 extra. And so even though that the provider gave the $5, they're still getting $25 extra because that the feds sent an extra 30. So it is very complex. I will tell you, most states have some type of mechanism like this, Iowa included. We in Iowa do provider taxes for nursing facilities. It's called a quality assessment fee. We do them for ICFIDs. We also do them for hospitals. Interestingly, at this point, for the provider tax perspective, this the provider tax and the directive payments piece, the nursing facilities and ICFIDs are not going to be included, as states are being required to ramp some of these things down or change their methodology to be more in line with what the federal government would like. But it really, really applies pointedly towards hospitals. So hospitals are going to be really, really heavily impacted. In Iowa alone, our provider tax and directed payment program brings in an additional $900 million a year for hospitals. When that goes away at the end of 2034, it's going to be a pretty big gap. And I don't think that the state has that $900 million to backfill the rates. And so the state and hospitals, everybody's going to have to think about, what does that mean for the landscape of healthcare? And is there reasonable right sizing or restructuring that can happen to kind of right size towards sustainability? Or are we in a really true crisis? So the provider tax limits, it bans any new provider taxes, but for those provider taxes that are already in place, starting in 2028, the provider taxes will have to be reduced by 0.5% every year until they get down to that 3.5% cap. So in 2028 forward is when that hit will take effect. Same with the directed payment limits. So right now, for example, a lot of states that are using that provider tax to bring in additional non-federal share funds, they are using that to bring hospital rates up to the average commercial rate. So what the federal government has said is, you can't do that anymore. We're not going to pitch in to pay up to the commercial rate. We'll pitch in to pay up to Medicare, but that's it. And so again, you'll see kind of a difference in treatment between expansion and non-expansion states. For expansion states, they have to reduce, beginning in 2028, they have to reduce incrementally their directed payment structure from the average commercial rate down to 100% of Medicare, starting in 2028, 10% a year. In non-expansion states, they have to do the same thing, but they have to reduce it down to 110% of Medicare. To give you kind of like an idea of scale, commercial pays roughly 2 times what Medicare pays. The error penalty rates, so every few years, states go through a pretty big payment error audit by the federal government. It's called PERM, Payment Error Something Monitoring. So that PERM audit assesses like what's the inaccuracy rate that states have in terms of paying claims to providers. And so they'll look at the actual payment rate, they'll look at the type of service that was provided, they'll look at the individual's eligibility at that time, and then they'll assess, okay, Iowa, you have a 7% error rate. You know, I'm just making up numbers. You need to pay back X number of dollars. Well, in the back and forth between states and the feds, usually there's some type of deal that is struck. Say like, okay, well, we'll pay back X amount. And the feds are usually somewhat agreeable to that. But this puts in place a hard cap saying HHS, federal HHS no longer has the authority to waive anything for states that have an error rate above 3.5%. So that is a big deal, because usually when states do have those big error rate penalties that they have to pay back, one mechanism that they can help do that is they collect those payments back from providers. And so I just see that as possibly one additional way that providers could get hit through some of this legislation. So some things that aren't Medicaid specific but are in OBA that are a big deal. There's some updates for SNAP work requirements as well. SNAP has had work requirements for able-bodied adults for many years. And for those who don't know off the top of your head, SNAP is the food assistance program. And so they're tightening those up a little bit, adding some additional requirements. They still don't match the Medicaid work requirements. And so states will be having to still kind of operate 2 different disparate programs. But what I do anticipate, states will try to find as much alignment as possible so that they can benefit from each other. Hospitals get paid a supplemental payment of a type if they serve a high number of Medicaid individuals, if like their mix is very high Medicaid. That's called DISH. It's set to expire at the end of this calendar year, and that was not protected in the OBA. I hope we'll see that. I don't anticipate that'll go away, but I do bring it up because it's one more thing that's not protected and kind of in danger. Same with the marketplace subsidies. So with the Affordable Care Act individual plans that can be purchased on the marketplace, there have been pretty generous subsidies in the past 5 years for individuals seeking coverage. So much so that, if you are under a certain percent, I think 200% of the federal poverty limit, you've basically been able to get health insurance coverage for little to no cost on the marketplace. Those sunset at the end of this year. And I do not anticipate those continuing. So that'll be one additional pressure point as well. Also, with some of the budget neutrality rules that are in place at the federal government, if the way that certain policy items are structured, if there is an overage, certain things have to be sequestered for funding. And so it does appear that there will be a Medicare sequestration of funds, which means that there will basically be a hold on a certain amount of funds that can help accommodate other overages and other areas of the federal government budget. And that means that it looks like there could be a 4% Medicare provider reimbursement cut as well. So just kind of keep that in mind. Everybody's getting hit from every direction. And then one other thing that I just want folks to kind of keep on their radar is there was a lot of changes in there related to state and local taxes. And so there are some different caps on the local tax thresholds. And I just point that out because there are probably going to be scenarios in communities where they're going to be losing revenue that they might have already had and have been using that revenue to help support social and healthcare programs at the local level. Just something to keep in mind. I don't know of anything tremendously impactful in Iowa specifically, but all of the confluence of all of these things is just something to understand. Here's the timeline of how these things roll out. So if you look at, we see, really effective immediately. Those Biden era rules have been suspended. They're not going to go into effect until at least 2034. And it shows for different things when each component starts hitting. 2028 will be definitely the big year because you're going to be seeing adjustments to states' ability to tax providers, as well as their ability to use those tax or intergovernmental transfer dollars to pay providers more. That flexibility starts being eroded. So just at a high level, OVA, by 2024, they're projecting about 10 million additional people will be uninsured because of these changes. I've heard other sources indicate it could be as high as 15 million because this CBO did not take into account the marketplace subsidies ending at the end of this calendar year when they did the uninsured projection. Half of the 10 million will be uninsured by 2027. So in the next couple of years. Overall, the OBA reduces funding to state Medicaid programs by about $900 billion over 10 years. It's a lot. And also the marketplace funding is reduced as well. Now, all of this assumes that we're just going to continue plugging away and that nobody's going to protest it legally. I find we are already seeing legal protests pop up across the country. I think work requirements are a done deal. I think that everybody's pretty locked in on that. I think that's going to be a hard one to back away from. Some of the other changes, there might be some wiggle room in terms of between states and the feds and the different healthcare provider associations, a way to make the goal roll out in a way that is less immediately impactful to the individuals that depend on services. So realistically, what does this mean? I want to highlight first and foremost, that everybody that I know, including hospital associations and large association lobbyists. I mean, everybody has been pretty diligent about saying this cannot impact individuals with disabilities, or the populations really that Medicaid was originally designed to serve. And at the highest level, OBA didn't directly impact individuals with disabilities or the populations that Medicaid was originally designed to serve, but it impacts the system that serves those individuals. And so that's just what I want, folks to keep in mind, is like, this will put a tremendous amount of pressure on state budgets. And so as we're thinking about things that need to be changed or modified within the context of Iowa Medicaid, I want to just suggest that anything that is additive at this point is going to be hard. It's going to be real hard. So if there is something that needs to be changed, it's going to probably come at the cost of something else at this point. And so are there ways that we can think about the system as a whole and be proactive in terms of giving our Medicaid partners information about are there some services that are they're really not great. They're not benefiting people. Let's just take those off the table and use that money to invest in something else. I think those are the kind of formulas and the kind of calculus that all of you need to be thinking through as you're having conversations with legislators as well as state Medicaid agency partners. Also, the system is just going to be real stressed. So hospitals are going to be real stressed. Home health is largely connected to hospital healthcare systems, so they're going to be really stressed. As much as we can kind of think of ourselves as part of a village and how we can support each other, I think we'll end up better off. This could result in a decline in access to services. I'm just going to call it the way it is. If a hospital cannot maintain financial operations and has to close, that is a door that closes to somebody in that area, and they'll have to make other arrangements. I also think that this is we're once again in an era of program integrity focus. And so just kind of keep in mind, people are going to be leaning back into how do we double check? How do we triple check? How do we make sure that individuals got the services that they were supposed to get? How do we make sure that the services are of the highest quality and benefiting the people that we serve? So the return on investment is going to be a top priority. So the Kaiser Family Foundation, they have a website. They've been keeping really close tabs on the OBA, as well as a few other sources that I cite later on in the presentation, just so that you guys can look around and explore as well. This shows really the intensity of federal funding cuts to the state based on the provisions that are in OBA. Just highlight Iowa is in that kind of highest tier of that the impact will be, it's not day one, it's not 2026, but it will be 2028 moving forward for most of these, where Iowa will start to see a 13% or above cut in how much money they're getting from the federal government. this shows, this is also from the Kaiser Family Foundation. It shows where the timing of these federal cuts happen. So year over year, what the amount of reduced funding looks like. I do like this visual because it shows pretty clearly that the cuts will start, the majority of the cuts will start to feel painful, really painful in 2030 moving forward. So it's not going to be this year, next year, or the year after, but it will be in 5 years, which is going to be just around the corner. And so this is a good opportunity to be planning for that and what is plan A, B, and C. So what kind of state levers are there to mitigate the reduction in federal funding? States can, you can ignore these reference points to other slides because those they're in the appendix. You can look in the appendix. States may start looking at optional eligibility groups and services. So not every service, there are mandatory services that all states have to offer through Medicaid, but then there's a whole other subgrouping of optional services and optional people that they can cover. States are going to start looking at those pretty closely to see, do they want to continue those optional eligibility groups and services? They can start looking at, Gayla, Amy, I think you guys were around back in the day when we had an across the board provider cut, 2008-ish. Back during the Culver administration, there was an across the board cut for all providers under Medicaid. It was very, very, very painful. Ended up a couple years later getting turned around, but that is something states will be looking at. If they do not have the budget to cover different losses, they're going to have to figure out ways to make the accounting work. Also, just increase program integrity efforts. And I think other aspects are just thinking through, are there other creative ways to fund programs? I think that states, desperation creates innovation, I think is what I've heard. And so I think that there will be new and different ways that people are going to be looking at configuring and funding Medicaid services moving forward. And that's probably the bright side of the bill, is we should have some good innovation come out of it. So I included some links to resources that I consider to be reputable. They're not biased in terms of reporting. They don't tend to be kind of fear-mongering, which some other state or some other websites are. They just provide good information. And so that is one avenue. Also, I know that the Iowa Medicaid agency has regular meetings externally with providers and members. And then as the beneficiary advisory committee gets launched with MAC, that's another good avenue, as well as MAC, to continue to stay engaged as well. So I just really encourage folks to keep up to date in terms of like what is coming down the pike, and just keep close with your Medicaid friends and keep talking about what they're thinking about doing, because they're going to need a lot of ideas and assistance in weathering the changes of the storm as well. So like I said, there's some information at the end of this slide too, just kind of showing how states compared to each other for spending and enrollment as a percentage of their population. It talks about eligibility categories. Here's where you have your mandatory and optional eligibility categories. One of the biggest optional categories is the expansion population. So I would not put it past some states. In fact, I believe that Idaho maybe is thinking about it already, but thinking about getting rid of expansion or not going towards expansion. Like they're changing their minds about how they're going to approach it. So that could be one way that states think about alleviating the impact. Here's some mandatory versus optional services. This is not comprehensive at all, so I do recommend clicking the link if you want to have a more comprehensive list of what those optional services look like. And just here's Medicaid managed care enrollment, how some different federal match percentages, how the feds assist in Medicaid financing. It is different based on different things. And so, I mean, God bless our budgeting team in every state because they do a lot of crazy math. And then this is a really simple chart that illustrates provider taxes and directed payments. Good luck. No, I'm kidding. If you I can sit down with folks at any time later and walk through it more in depth if folks are like, I don't even understand what directed payments are. So, Amy, I will open it up for questions.
Liz, thank you so much. Anybody who has questions or comments, please feel free to unmute and or you can raise your hand. Kay, jump on in.
Okay, and I will let y'all see me.
Okay.
Well, first I want to start off by saying it's so good to see you, Liz. We do miss you. And I totally agree with what Amy said in her introduction. You set a standard for engagement with providers and members. And we're hopeful that the gentleman who's coming in will meet that standard. But he's got a high bar to reach that you set.
Let me just Kay, I'm so glad you brought up Lee. I have known Lee Grossman for several years. He is wonderful. And when he was announced as the new Medicaid director, I myself had a huge sense of relief. So
well, that's a relief for us too. But like I said, we're hopeful. A couple of comments and then questions. Certainly take to heart what you say about us being kind to the folks who work in the Medicaid agency. I think we all they were already working very hard, and they're going to be working harder. And so we should keep that in mind. But I would also submit, and I hope that they do, I again am hopeful they do, recognize the fear.
Oh, yeah.
The desperateness that Medicaid recipients and their families are feeling. And so our reaction at times may not be what we would like and be harsh. It truly, I want to say it's not personal, but it is personal to us. Yeah. And it is very scary. So, just to make that comment. But I guess my main question is whether or not anyone is looking at, a major issue that we talked about all the time and remains a crisis is the direct support. I know some of Joel's workers were part of the expansion. That's how they get their health care. And I'm just curious how again, the sunsetting of the subsidies that probably help a lot of these people, the increase in the copay. At least one of Joel's workers is very scared of what's going to happen with her stuff, and that will impact Joel. She may not be able to continue working. So again, has anybody talked about that? Looked at that? I think they can meet the work requirement, most of them. So the work requirement is not the issue. It's the loss of the subsidy and possibly other changes.
What I will say is, Kay, I can't speak on behalf of Iowa Medicaid, so that's a good question for them. But I will tell you at the national level, there certainly has been conversations and concerns expressed for about the number of direct care workers and even HCBS agency employees who are covered through Medicaid, usually through Iowa Health and Wellness. I think when I was still with Iowa Medicaid, we did a sample of some agency employee rosters to just see how many people were enrolled in Medicaid and also working full-time. And it varied by agency, but if we looked at it, it was about 20 to 25%. And so I think that is a really good point, and it's something that the group collective is. We're all going to have to think about how we support those individuals moving forward.
There was one other thing. In regards to the work requirement and the reporting, that already occurs in one form or another. I know for Joel, we report every month we report how many hours he worked, what his salary was, what his earned wages were to Social Security. And we report it to his supported employment provider on a quarterly basis. So that information is already being captured by others. And so I'm just wondering if that could help ease the, let's not duplicate what people have to provide. That information is available if you're working.
I think, Kay, that's a wonderful point, and that's definitely what states are thinking through. They do not want to create a new structure if something else is already available, because it's duplicative work for the state, and it's also duplicative work for the person. So the only thing I would say in regards to Joel is, he's on Social Security because of his disability. He's going to be automatically excluded from the work requirement component.
Right. I'm not worried about that.
And most able-bodied folks are not reporting to Social Security, but they might be reporting to workforce development. They might be reporting to for their food assistance. And so how do we leverage that information? I wish that it was as easy as just getting information from the IRS and saying, okay, just give us all of the employer reported wage information. And that's how we'll validate it. Well, so much of our economy now is gig economy, where it's off the books 1099 workers, like Uber Eats, DoorDash, all of the things that people do not receive paychecks for anymore is kind of dominating the scene. And there's not a great system to aggregate that information yet.
really, you're so comprehensive. That's why we love you and rely on you, because you consider all those things. And just one final comment, it is scary, because I was in a meeting recently where a representative from one of the managed care organizations actually said, we are looking at, sorry, and this was for people with receiving home and community-based services, reducing access, to certain services because of the Medicaid cuts that are coming. So that's the fear.
Yeah.
It's already being, and we're seeing it happen to people now with not getting prior authorizations renewed that they've had for years. So just appreciate everything you're doing, and thanks for being here.
Thanks, Kay.
Thank you, Kay. Bill.
Thank you, and thank you, Liz, for being here. We do miss you, and I was never afraid to be very vocal about things that I was concerned with, and I've always appreciated your response. It was good, and I hope that can continue. One couple words that a lot of people in Congress tend to use, and you did kind of mention it, was fear mongering with respect to another agency. I absolutely deplore that word. As Kay pointed out, we're worried. And no, on the surface, this doesn't necessarily impact our loved ones, but they could become collateral damage in terms of what happens when rural hospitals close, or they no longer can provide services to including our folks. If you don't have a provider, you're just not going to do well. I guess mine are more comments versus questions. And I'm so glad that you're still in the arena. I really am. And it kind of seems weird to me that we talk about work requirements, but at the same time, and we're the Iowa Coalition for Integration and Employment, so I focus on that. I believe in that. At the same time, they rescinded all of the Department of Labor recommendations to end 14C, which is the provision that provides for subminimum wage. So we want our people with disabilities to end up in workshops, but we're going to require everybody else to work. I guess I think of families that have, and I know you mentioned it wouldn't impact people with loved ones under age 14, something to that effect. What about a family member who has a person living with them with a disability that is over 14? They aren't just sitting there on their hands. They can't work because there's nobody to take care or provide services necessarily for their loved one. So it all seems to me that where it will impact us is through collateral damage. But I guess the rescinding the Department of Labor recs really bothered me. At the same time, when we're expecting everybody else to work and get good paying jobs, but we think it's okay to pay our people with disabilities sometimes pennies per hour. So I'll get off my soapbox, but that it ultimately does concern me. So that's a genuine concern. But thank you again.
Yeah, my pleasure, Bill. And those are all very good insights. I think you pointed out how important words are. And so I'm going to think about how I can reframe that for the next time I'm talking to folks. I think that the space where I really just want to gently nudge people from staying away from are platforms that are really focused on rumor and kind of gossipy insights, because that's not always solid information. And I want, if people are going to be afraid and angry, I want them to be afraid and angry about facts. like real information and not things that can easily be dismissed or damage their own credibility when they come forward angry and fearful. So let me just say, I get it. Like I am afraid. I think that we're going to work through it. And I think that because we are all very creative and innovative and protective of this program, that it will be okay. But I understand the fear for sure.
Thank you, Bill. Thank you, Liz. Gila, you had a comment you put in the chat. Do you want to go ahead and just post that?
Sure. I noticed when you were putting up the slides about optional services, et cetera, that HCBS made that list. Is there strong support for that universally, that might not be as impacted as maybe some of the other services that looked optional? I'm hoping that we look like the star in the class when we talk about HCBS.
Yeah, I mean, I think on the optional list, there are a few that are probably, people kind of roll their eyes when they're referred to as optional because states are like, they're not real. Like we really couldn't get rid of them. And that's HCBS, pharmacy, some of the non-required home health. Like we have to do those. And so I think that there's a reasonable amount of hope around the fact that HCBS as an optional service will be held harmless in some of this. However, I say that only to kind of follow up with a little bit of a maybe depressing insight, which is that states may be reducing their wait lists slower than what they originally had targeted with some of these changes. The other thing that is protecting HCBS to some extent is the fact that institutional services are required. And to the extent that those will remain more expensive than home and community-based services, states are always going to want a less costly intervention alternative.
Good. I put it out there mostly because we've all seen different things happen within recent times, things being removed, adjusted, etc. That it's like, I would think that HCBS would be one of the last on the list to be impacted. It might reduce funding based on what you said earlier about Medicaid payment, but I just worry about what cockamamie idea might be implemented. So thank you, Liz. You give me comfort.
Liz, I feel like we could ask questions for the next 15 hours. I know sure. I have like a million, but I know that Dawn is here and giving us a window of time to talk about state changes. So we might see if there's a time we can invite you back. So I greatly appreciate your time and your insight and your expertise really in thinking through how these things connect, because it seems very complicated. But there were so many things you said that resonated with me and my thinking. And one of the things that really sticks out is that innovation and community. And how do we come together to figure this out, to make sure our communities are healthy and safe and have options? And so, I think there's an element of that where we bring in different folks to help kind of guide considerations around that. So we may be reaching out again. For any of you who are looking for an amazing consultant, please check out Liz. I'm afraid we can't pay her, but some of you can, and I think that I think this is going to be something that we would all benefit from, those solid facts and those talking points, because every time I reach out to share concerns, it is kind of dismissed. But really, the big picture is, well, you may not be focused on this population, but all these other things impact our communities, impact people in our communities, impact our workforce, impact, our families. And so, trying to find a way to have those conversations that are not partisan, but are just, here's just the facts, ma'am.
Yeah.
So, thank you, Liz. Thank you for your time.
Thank you, everybody. It was wonderful to see you.
We're going to just move right in to Dawn. Thank you for your patience, Dawn. This is just so much right now at the federal and state level. And I'm just going to make one final comment, and then I'm going to lob it over to you to give us a kind of a state overview. But, as we talk about the possible changes coming from the federal level, even if we don't know all the details of how the state will respond to that, it does make me think a lot about the impact as well with what restructuring we're doing in the state and impact to services and providers. And so this is a perfect sort of segue to all of the amazing things that are occurring in the state, and how we can closely work with the state in thinking about the federal and the state changes, and supporting all the folks who are trying to make that good and possible. So I'm gonna turn it over to you, Don. Thank you.
Well, thank you so much, Amy. Yeah, we have a lot of change at both the federal and state level right now going on. So it's a lot to keep track of, and a lot to be thoughtful about how all of it connects, to have a comprehensive system to the people that we serve. So I'm going to go ahead and share my screen. There we go. Are you able to see my screen? Yep. Okay. So I'm Dawn Keckstead. I am currently the Deputy Director of our Division of Aging and Disability Services at Iowa HHS. And I'm here today to talk about our alignment with disability services. So 2 legislative sessions ago, we had some significant changes to the behavioral health services and disability services. And the big changes that we are implementing in our division are around the untangling of disability services from behavioral health services. So we created behavioral health, which was mental health with a separate substance use disorder. So created behavioral health, and then untangled from that the disability services, because we felt that really needed its own attention and lived in our system. And a part of our ability to implement some changes was also the ability to expand our aging and disability resource centers and who could be member organizations for those. And so it opened it up from what had been our area agencies on aging, or our AAAs, who are definitely subject matter experts in serving Iowans over the age of 60, and caregivers, older caregivers for people with disabilities, to other entities who have expertise specifically in disabilities. And so we put out an RFP to have lead entities in 7 districts across the state for disability services. And we call those entities, our lead entities, disability access points. So you may hear access points, disability access points. Some people shorten it to DAPS. But the real, we align the districts with behavioral health. We know that while we're untangling how we administer our programs, that people don't like experience our needs for the system in silos. And so we are aligned with 7 districts. And across those 7 districts, we ended up with 4 contractors for that. And so it happens that those 4 contractors were also historically MHDS regions. And so they were very familiar with the work we were getting. They have embraced the future vision that we put out there and have done that. So just to get people familiar, if we start on the west side of the state, District 1 and District 4 have the same disability access point administrator, which is Western Iowa Service Collaborative. And then District 5 is Behavioral Health and Disability Services. And then districts 2, 3, and 6 are all collaborative individual and community supports. And then District 7 is MHDS of the East Central region. So I do in this PowerPoint, which you guys will get a copy of, we do have a link to our website that shares this map. We have an interactive map that people, if they're wondering where their county lives and what that contact information is, they can click on that and get contact information as well. I do want to point out that even though we have some individuals who were our entities that used to be MHDS regions, we have had a lot of name changes. So they are all familiar people, but not the same names. And that's in recognition of a changing system and a changing scope of work they're looking at doing. And our MHDS East Central region is in the process of changing their name as well to be more reflective of the current work. So we have an array of services available, and I would point out that as we kind of work our way through the continuum that we built into the system, that when we talk about long-term services and support, those are non-Medicaid. So the changes that we've made in that arena are not to anybody's like Medicaid services or that, but we start with navigation and no wrong door, and that is a part of our Aging and Disability Resource Center philosophy, right? That ADRC approach is navigation is no wrong door. If you think that there's a need, if you have a need and you want to reach out, we are going to assist you in these spaces. And if you reach out to the behavioral health ASO because you think maybe that's what it is, that is also not a wrong door, and they will assist you in any way that they need to. And we'll make sure you get connected to the right part of the system to help you meet your needs. And so in moving to this kind of statewide umbrella approach, though, we really want people to have reliable and trusted information. You shouldn't have access to information and make decisions based on the person's experience whose door you walk through, right? Like we have an ability on a statewide basis now to provide information about the system, how to work your way through it, and to support you in making those person-centered decisions for yourself or your family member in the system. So it's connection to services and resources across the state. And that person-centered approach. It really is, what are you coming in for? What information do you need to make the best decisions for yourself? We then have a little bit of a longer term. Sometimes that one-off or kind of two-off conversation with people in a navigation space isn't quite enough. And maybe somebody has kind of a shorter term need that is maybe, we kind of put the parameters of about a 90 days, but we say 90 days-ish because we know that it doesn't. It may be 1 month, it may be a 2 month, it may be 3 months, it may be a little bit longer than that, but it is kind of the shorter term need where maybe someone can help work through some of that shorter term space for people, offer them support through multiple issues. And with that, we've provided some also just some services with that too, because maybe you don't need long-term services. Maybe we can connect to another part of the service. So really time limited. Supporting people, this is really our front end space, right? Like we want to support people in their home and community of their choice. And if a little extra support to do that on a short-term basis is helpful, then we want to offer that in that space. And then just an integrated manner of offering support to families and their caregivers as needed for this purpose. And so we do try to call out caregivers in this space, right? Everybody needs natural supports and people in their lives. And we know that caregivers offer a lot to the people that we're serving in this space. And we've provided some support in that area as well. When we talk about some of those short-term services, so not only is there that what we call options counseling, or kind of that 90-day person-centered approach to working with people through their goals, we also have some services that we've provided some funding to. So some of that space around individual assessment or evaluation. We know that access to services frequently takes that, and that sometimes a holdup when people come up on like wait lists or things like that have to do around that assessment period. So trying to support people through that. Transportation, respite. So we have respite in both our long-term and short-term space, but sometimes people just need a shorter-term space for that, or in the summer, families maybe need some camperships. So we did put that in both parts of our system. Peer and parent support, time-limited rental assistance. Sometimes as people are transitioning between different settings, it may take a minute to get hooked back up to benefits, and so we can provide some of that assistance there. Home and vehicle modification, adaptive to equipment, and we have a little broader category of other basic needs, because sometimes you have to be creative and flexible to get people what they need, and so we do have a space for that. And we would expect that their disability access points would be able to connect you to those resources. And then we move a little bit deeper into the system for support. And so again, when I talk about service coordination and long-term services, we're talking about non-Medicaid. This is our gap filling space, our safety net space for people with disabilities. So it's a longer-term support as you're moving past that 90-day mark and needing some longer-term support. We recognize that that may look a little different for people. It continues to be to support people to live in their home and community of their choice, and be as integrated and independent as possible. But also, we have a space where we have people who are in facilities and looking to transition to community. And so really looking at that service coordination and what does that transition look like? How do we set up resources and supports to help make that successful for people? And then also facility diversion. So if somebody's on that track and they need some extra supports and services, the disability access points are able to assist in authorizing some of those services. And when we talk about those services, they should look somewhat familiar. If you're familiar with HCBS waivers, we're very aligned in that space. So supported community living, or SCL, day habilitation, some of our residential programs, medical and service supplies, personal emergency response systems, supported employment, respite, and some pre-vocational services. Transition has been big. We went live July 1, but there was a lot of work leading up to that. And so our focus, while we have a future state vision for this, we knew that we were serving a lot of people in that MHDS region space. And because we chose to make a change in how we administer a program, we didn't want to create a lot of disruption to those individuals. So we focused very much on warm handoffs for service coordination of LTSS. So if somebody was being served in an MHDS region, we wanted to make sure that they had a conversation, if we could, between their previous care coordinator and their new service coordinator, so that we could do that. We also worked a little bit on some deduplication. We knew that people had lots of case managers, and so we did help people connect back with some of their MCOs and their case managers at the MCOs and that. So I will share some numbers about where we landed with people that we're currently serving, but in about a time frame, May and June, our disability access points had 3,000 contacts with individuals for warm handoffs. It was a breathtaking amount of work and transition time, but it was really important focus for us in this space. We've also been doing a lot of provider outreach, communication and training. We've changed a little bit how providers get paid in that long-term space. We moved it to the claiming system with the state instead of individualized contracts with each of the entities. And so we've been doing a lot of outreach. Talking about continuity of care, there's a space where if somebody was getting it through the MHGS region, we're absolutely going to guarantee it through the end of December, just while we have time to assess and see how they fit into the new system and how that translates. So doing a lot of communication. We had some provider town halls to help share information. We've been doing a lot of talking just to support that and make them feel comfortable in understanding that they'll continue to get paid for their services, try to create little disruption. We did engagement and outreach just to try to keep our community and the people who access and use our system informed of our changes. And then we are currently embarking on the establishment of our disability services district advisory councils. So each disability access point in each district, so even if they have multiple contracts, each district will have their own advisory council. They are required to be made up of at least 50% people with lived experience or a caregiver. And so we have had open applications for those right now and are working on getting those established so that they can start meetings in October. But the goal of those district advisory councils really is kind of the shared responsibility model, right? Like, how do we connect to the district that we serve? Get their feedback and guidance on decision points and processes and how our changes are playing out so that that can help establish and guide some of our future work as we shift the system. And then I wanted to share, we have first month, we went live July 1, and we have some information about how that went. And so we, for disability access points, we are landing with serving about 2,400 individuals in the state. And options counseling is that 90-day space that we talked about with the disability access points. So that is a brand new space for people. And so they already had maybe some connections with an MHDS region, still needed some additional connections. So we transitioned and actually added about 150 people to that space of short-term support, person-centered guidance. We developed a category of funding navigation only. So we recognize that sometimes people have an MCO, they have a case manager, or perhaps an integrated health home, or now as we're moving to future state, those CCBHCs and a case manager don't necessarily have to have all the case managers in order to get your needs met. And so we created a funding navigation space where we're still making sure it's appropriate, but the people are getting the services they need. And we had about 1,100 people move into that category. And then that long-term service coordination, we had just right around that 945 mark for people. So that is the breakdown of the people that we transitioned into our system in that first month for Go Live and kind of what programs they're landing in. And then in our first month of implementation, information and assistance. This is a brand new thing, a bright front door for people with disabilities to be able to call, their caregivers to be able to call and get information. And we had in our first month across our disability access points, 280 calls. So people who we tracked whether or not they had had contact with the MHDS region or not before. And the great majority of them, I think we were at like 78% of those calls were people who had never had contact before. So exciting for us in the first month to have that. We did a major campaign and people heard it. So we are hoping to keep numbers high and for people to feel like we have a great space. And we also looked at why they're calling, what are they looking for? And so we had 95 individuals call for access to services, 87 for information on resources, 35 looking for assistance with those basic needs, 23 seeking assistance with completing applications, and then 40 looking for other supports. So as we move through this and start looking at those numbers, we might be looking at that other support category and seeing if we need to break that down a little bit. But for 1 month, when you think about all the warm handoffs that the disability access points did, that's a lot of work. And so we're excited with this information and that this many people are getting support right out of the gate. So we do have our disability services information on our website, and that's included in the PowerPoint. And then also just very clear that we are always in parallel and working so closely with behavioral health, because we know that connection is so significant for people accessing our system. So always include those updates as well. And then still just want to make sure that people know, right? Like, we think we caught people. We're finding new people every day because of some of the transition stuff, but people do have a way to self-identify if they were involved with an MHGS region before and leaning on them for support and assistance, and they didn't get a warm handoff or they didn't hear from somebody. We want to hear from them. So nobody is left hanging out there not knowing what's happening or not getting the support they need. So we did provide a way for people to self-identify. Providers or loved ones can assist people in self-identifying as well. And then I will just open it up now to questions. That was a lot of information really fast, so happy to answer some questions.
Thank you so much, Dawn. Do folks want to just unmute and jump in? You can put things in the chat. You can raise hands. You can engage however it's most comfortable for you. Dawn, I have a question. I guess I don't know if it's a question. It's a question, but I think it's going to be a hard one to answer right now. But thinking about what the information that Liz shared with us, excuse me, about, you know, changes in resources, potential impact on state resources, the array of options that states might have in service provision. You know, I know that none of us know exactly what that's going to look like in our state. But as you were speaking about, you know, kind of that safety net.
Yep.
One of the things that occurs to me is there's going to be more people needing that safety net.
Yep.
And so as we as we as a larger community want to really think about impact and need, I'm just curious, like how we can sort of tie these together and pay attention to the right things. And you know, like I'm just thinking, I'm sorry, I'm kind of rambling, but I'm just thinking that there will be greater need, especially as that timeline that we looked at and where there's more significant cuts coming in 2028. So is there, you know, from your perspective, will there be attention given to planning, and then what kind of support our state will need to ensure that that safety net is there for folks? I don't know if there's a question in there.
No, I think right, like you're verbalizing what we're all thinking about and have on mind, right? Top of mind. And right now, in preparation for some of that, like this is the first time as a state we've really had a direct line of sight in the entire state on these services and the need, right? Also, historically, the MHGS region served people with intellectual and developmental disabilities. A few of them served people with brain injuries, and then they also served adults only, right? So we've been tasked with expanded, right? Like there is no age group restriction and there is no definition of disability, right? Like it is, if it's a disability under the ADA It falls under our purview. So it's a big time of change for us right now. And so we really feel like our task is like, let's first see what we have. What do we have for sure across the state? And how do we ensure equal access? We know that it really was dependent prior to what county or region you lived in, what you had access to for states. We're really tasked with thinking through, like, how do we make that more equal across the state, or how do we address access across the state? Also, then figuring out, like, where have we had duplications, and we can find things that work better for individuals. How do we help them work through the system? Right. So there's been a bit of disjointed connection, not because of like negative intent in any way. Everybody's doing the best they could with the system we had in place. But how do we make sure that we have the appropriate connections with the Medicaid space, with behavioral health, with, right, like our eligibility programs, and all of that, so that we can have it in place as we experience changes. We'll be able to figure out and watch the data and understand it. And then in our navigation space, people are going to have questions, right? And so we have to be really prepared in our navigation space to answer questions and help people navigate through all those changes. So we're really just trying to put the structure in place today, understand our need, collect information and data that we've never been able to collect before, so that we can assist in some of that informed decision making as a state. But we rely on our community, right? Like, we built in shared responsibility on a community level, on an access point level, and on an HHS level, because it is so important to have the people who are experiencing our system, the providers, all the people who are engaged in this, providing us with that feedback, right? And we need that information to be able to make those decisions. So, but yeah, I also am rambling, Amy, because it is a lot to think about, right? And to try to get together. But it's on our site. We think about it every day. And we really built a system around trying to keep the people we're serving in mind, right? That's really what it's about. And how do we make that functional for people?
Do you have any asks done for folks? We have people from all across the state and kind of coming with different perspectives. Are there any asks that you have that would help you as you build this and roll it out?
I do. So we have open application right now at all of our access points for our advisory councils, and your voice matters, right? Like, we need people to engage. And we've had a bit of difficulty. We've extended our timeline for applications because we've not necessarily, in a few areas, not had kind of the response we've been hoping for. So and we want to be really careful across the districts. They're big districts, right? And there's a wide variety of need. And disability is such a broad topic as well. And people have such a broad experience that we want to be thoughtful about who is joining that and sharing their voice. So I would encourage people to get on the website. It will connect you to our disability access points in the applications. Please consider being a part of that. I know it takes a lot when people are sitting on a lot of different councils and advisory things, and we have a lot of them going on, but your voice matters. And if you have somebody you think would be great, encourage them to apply as well.
It's fabulous. Thank you.
Yeah.
Other folks have any questions or comments for Dawn? I know that one of the things that I've experienced over the last few years is sometimes a disconnect for our educators and those supporting youth with understanding kind of the system and being able to kind of communicate that out with families and individuals. And so I know that we tend to get a nice group of educators involved, but I just want to encourage educators and those that support educators as well to think about those advisory councils, because sometimes we have a disconnect, between our systems of those that serve youth and those that serve adults. And so we'll share information with everybody on, and when is the deadline for the application?
Yeah, they are all open right now. And I think this week was closing, but we've decided to extend just to make sure that we get a broad one. So I think we are going for one more week, which I know is a little bit short, but also if we're not getting what we need, we'll continue. It's important that we build a great base here. So we'll do that. And then with meetings starting in October. So I think everybody has a one more week open for people. So end of next week.
Perfect. Thank you. Thank you so much, Dawn. I really, really appreciate your time and your willingness to come and share. Because I think there's a lot going on in your department right now.
There is a lot going on. Yes.
Thank you. Thank you so much. All right. We're gonna jump to Jenny Erdman. Jenny, it's good to see your face. I've had the honor of getting to work with Jenny over the years, and I haven't seen her for a while. So I just invited her so I could see her.
It's been a while for sure.
Jenny, it was Gayla Harkin who brought up in our core team meeting the needs of the integrated health home, and timeline and what's happening. And again, one more big piece of things that have been a major part of our system for so long. And so we asked Jenny to come and give us some insight into what's happening around that and the sunset of the integrated health homes and kind of what's going to evolve. So Jenny, I don't know if you have a presentation or if you're just going to share things, but if you have a presentation, I'll share it with folks after the meeting. Otherwise, we'll just listen to you. Give us an overview. Thank you.
Yeah, thanks for having me. So like Amy mentioned, and I'm sure most of you are aware of, the Integrative Health Home Program is scheduled to be sunset by the end of the year. So that's 12/31/2025. We have started that transition officially in July. And with July, we really focused on adults, not only adults who are on habilitation, but also those adults that might not be receiving intensive case management through a waiver or through the habilitation. And then we started August 1st with the children. So that just kicked off. And this has really been a coordinated effort with the MCOs and the integrative health homes, where we have an official transition document that we used and we've used for years with the integrative health home program, as we've had other providers term out at times for a variety of reasons. But we've really worked through a lot of those issues that we've had or been able to. So this has been a nice tool for them to use. So the providers and the MCOs fill it out together by individual member, and they really look at what those needs are to make sure we're not losing anybody, as trying as hard as possible to keep that continuity of care during this time, because we know it's hard. So kids just kicked off. We just got those transition documents from the providers last week. And so those calls with children and youth are really probably just ramping up. We have been seeing some of the providers who have fully transitioned or will be fully transitioning their members request to term early. So some providers you might see or hear about are ending earlier than that 12/31. And so what we have done is we have a Facebook page, social media. On our website, we have an integrative health home page that we've had for years, but now we have really transitioned that into the place for everybody to go to get updates. So you can go there for our most up-to-date FAQs and like different information. So I think the plan will be eventually to just kind of keep those updates. So you can kind of keep an eye on like who's still open, because we know that gets confusing for families and members as well. So the ultimate goal will be that the adults will be fully transitioned by the end of September. And then again, that full adult and children will be all that transition will end December 30th, with the program itself ending the 31st of December. But like we've shared in a lot of spaces, I mean, we're working with people, so we know it's not going to be as easy as a date, right? So the MCOs and the providers know that, if we need to move those dates around, that's okay. We're trying to meet with everybody and have lots of conversations so we can be as supportive as possible. So appreciate the opportunity to come and talk to your group, and any feedback that anybody has on ways that we can help support everybody.
Thank you, Jenny. Kay put in the chat, this will show my lack of knowledge, but what are adults and children transitioning to from the integrated health home program? Kay, I think you articulated something that other folks might be wondering as well.
Yes, that's a great question. So the integrative health home program had been providing case management as like one of its, or we called it care coordination, and that was like one of the core services. So that case management function is going to shift to either HHS TCM, so Dawn's group, that or it will shift over to the MCO case management. And a lot of people aren't as familiar, but case management can look different ways within our MCOs. So they also have like a care management option. So it just kind of depends on the needs of the member. We also have seen over time for needs change, right? So members and families might see things, they might really need that care coordination or case management, or they might be in a space where they're doing fairly well, but they just need that connection point. So we've also have asked everybody to really look at, is it just connecting them to our new CCBHCs that are standing up or started standing up in July? Is it to another provider, CMHC in the community, or where they just know that they can go there and get help? And we're also trying to share a lot of information about the ASOs and the DAPs that Dawn shared. I'm sure I didn't catch all of her presentation, but I'm sure she shared a little bit about, and then also Your Life Iowa. So really just shifting that case management more to the MCOs and to TCM, and then looking at what services because we know not everybody might need all of that intensive case management.
Thank you, Jenny. Are there questions or comments for Jenny? I think sometimes when there's a change in case management, and some of you know this much better than I do, but there can be such an array in styles within case management that I would really encourage folks to pay attention to, as things transition, are people's needs being met? Are they clearly understanding the change? And as someone gets a new case manager, sometimes that new person may not know that person as well. So there might be a need for some support or some advocacy around the individual's needs. And, it's just a kind of an important thing to pay attention to. And that's sometimes where I think people can fall through the cracks, not intentionally by any means, but it's just something to really pay attention to.
And I know we definitely have that on our radar, and hopeful that with some of the warm handoffs that we've been working through with the providers and who have been great, the IHHs have really been really great with working with the MCOs and to try to alleviate that. Because yeah, you're right. Like a lot of times members have had that same care coordinator for many years, right? And so that connection can be hard to lose. And so that's kind of where we also were talking about, well, is there opportunities for other services within that agency so they still have that connection to that place? Because people come and go, right? So, but having that place to go to, it can make a huge difference. And I do have a slide deck that I've been sharing that I can send over to you. Amy, if you want to share with everybody that has the high level details. And then again, we if you go to the Iowa Medicaid website and you just search IHH, that page should come up. But I can put that link in the chat too. So
Thank you so much. Any other questions or comments? Diane seconded the good to see your face.
hello.
When I was inviting Jenny to come and speak at this meeting, my cat kept stepping on my keyboard. And Jenny's one of those folks that as the cat was stepping on the keyboard and all these, like letters, I just left it there and had to explain to Jenny that it was my cat. And I think it's something she appreciates.
I do.
Yeah. All right. Thank you so much, Jenny. I really appreciate it. Have a great day.
You too.
I think now we're gonna switch to any partner updates. I know we had put many on the spot to do a Medicaid update, but that's not going to work so well for this meeting. But we'll do one at our next meeting. But I know we had several people from ICIE. Do we have a? Oh, Misty, hi. Do you want to give an ICIE update?
I would love to give an ICIE update. We have lots going on over at Iowa ICIE right now. We are gearing up for our conference, which is kind of all conference all day right now. You probably have seen some emails come your way. If not, get on our email list so you can see those. Our conference is coming up September 22nd and 23rd, and we are super excited that we were able to have a wide range of folks from all over the country coming in to talk with attendees this year, do some great sessions. And as we've been talking about Medicaid today, we are lucky enough to get the new Medicaid director. Director Grossman's going to come talk with us, as well as another couple of folks, Director Rain and Ostrich, which I am sure I'm getting those names not great, but they're going to be with us along with Director Townsend from IWD. They're going to give us state updates on day 2. We're also going to get national updates from National ICIE. We're lucky enough that they're being able to come in person, as well as the CSAVR folks. Ashley Lance is going to do some updates there as well. We have so many good speakers coming this year that we are really, really excited. We're going to be at Prairie Meadows in Altoona this year, and we really would love for you to join us. We have tons of things going on. We have our awards nominations out right now. You can head over to our website to see that as well and to register for the conference. We have a t-shirt pre-sale for the conference going on right now. Those awards, I should say, we're going to be shutting down those around September 1st. So if you have somebody to nominate, or you can nominate yourself for all the awesome work that you're doing across the state, please go over there and do that. We also wanted to quick talk about, we still have spots on our board that we would love to fill with the folks here on the call and across the state. Although we had closed the form, please reach out to any one of the board members to be able to take a look at coming on the board and either nominate yourself again, or if you know somebody that would be great, nominate them as well. I see Nicole added our link into the chat. We have several board members on this call, so if I'm missing something, guys, let me know. One thing I really want to shout out, though, is Eva Castillo and I will be doing a community of practice next week on the 29th to talk about all things Iowa ICIE, what we've been up to, how you can be a member of ICIE and also be on the board. A lot of our, really what is the value of that membership and how you can make connections, the networking, all of those things. So come check us out the 29th. And Eva, I know I'm going to get this time off, 11:30 to 12:45, I believe that is. something like that. So yeah, we have lots going on. We've also been doing some mentorships for provider agencies across the state. We have such a wealth of knowledge of folks on our board that we've been really excited to take some of that and kind of put the newer providers, put it right underneath our wing and give them some guidance and best practices as they move forward in supported employment and competitive wage employment and really moving away from that 14C environment. So we've been really excited to do that. Let's see, did I miss anything? Oh, one thing, just watch our website. So when you register for the conference, we have had such a great response that we've had to open up some rooms at another hotel nearby, which is great. That's awesome. So be watching for that new link to come out as well. Guys, if I forgot anything, I think that's it. I think that's it in a nutshell. Holler if you think I forgot anything, other guys. But yeah.
Any
We got lots going
questions, questions or comments for Misty? Misty, if you or Eva share with me the community of practice that you're doing, I'll send it out to folks. I greatly appreciate that APSI has been making available these community of practices for folks who are members or non-members. And I really encourage folks, if you're not a member of APSI, to really think about. It's not very expensive and you get really a great value. And APSI, Iowa APSI, I think I say this often, but is really amazing and leaders in the country for what our local APSI does and takes on. And there is such a wealth of knowledge across all of the folks who have continually volunteered to make APSI such a strong organization in the state. If you're less experienced or newer to this work, seek out being on that board because you will get a family of support, and it's a great way to connect and learn. So I just encourage you to take a look at APSI and to join. So thank you, Misty. Anything else from anybody?
Thanks, Amy.
Yeah, thank you. Do we have any other partner announcements right now? All right. I think we'll actually wrap up early. But I'd like to just say a couple of things. So our next coalition meeting is November 20th, and it will be 10 to 12:30. It will be virtual again.
Yes, sir.
I mentioned this. Gay, I'm going to mute you, Gay. The next at the next meeting, one of the things that we hope to do is, we have been operating with no funding, which is fine, for a couple of years now, and we're really trying to figure out what the needs are in the community, and if people would like the coalition to continue, if they do want the coalition to continue, what would be the most beneficial to our membership in what that looks like. And so we need to kind of explore some of that. There might be some of you who are interested in being part of the leadership of ICIE. Maybe there's some of you who would like to take on sharing some facilitation of meetings. It could look lots of different ways. One of the things that I think today for me really just kind of brought things home was there's a lot happening, and there's so many moving pieces and so many changes that I really think there's value from my perspective in us staying connected and creating space where we can share what's happening, share concerns, share ideas. And I think as much as it's easy to say, let's come together and support our communities and work together on this. Even with the best intentions, our systems are structured in a way that almost makes that incredibly challenging. So I think what Liz shared and what Dawn shared and what Ginny shared in needing to have us really to weather these storms that I think are coming, we really have to work together, and we have to become innovative, and we have to look at the whole picture. We can't just stay in our lane, because that's not going to work. And that's a fair request from our federal government, to say we should be working more efficiently and we should be doing these things. But we also have to really pay attention to what my dear friend Glinda Ferrier used to say is unintended consequences, because there will be a lot of impact in our communities, and we need to be mindful and thoughtful and collaborative. And we can't just look at this system or that system or this system. We need to look at the whole system and how it can come together. And it's very easy, and I'll stop after this, but it's very easy right now to make things feel partisan or political. And it doesn't need to be partisan or political, because disability and our community members cross all lines in that realm. So we need to find ways to have these conversations. I think what Liz shared around solid factual information is really critical. And then paying attention to that big picture and impact is going to be critical. And we have a little bit of time, but not a lot of time. So that's my 2 cents. Sorry, you have to listen when we're running early to my 2 cents. Any other comments that folks might want to make? All right. Well then, thank you all so much for joining us. Please think about this and think about what you want from the coalition, what you might want to do as part of supporting the work. And we'll be in touch soon. So thank you all. Have a wonderful day.
Amy,
Mhm.
I just want to tell you how much I appreciate you and getting all this information together and out to all of us, because it is very much needed. So thank you so much.
Oh, my pleasure, Farah. I'm so glad you joined. Have a good school year.
Yes, you too. Thanks, Amy.
Thank you.
Bye.
Thanks, everybody.
Bye all.
Bye-bye.